Good morning, good afternoon, good evening, and good night to all friends from dear colleagues from all over the world. It's my honor to welcome you to the CPD Talks. I would like to welcome all attendees for joining us to sharing knowledge and understanding contemporary dentistry. We are now beginning the second episode of CPD Talks with one of the most inspiring clinicians, a leader name, and a magician from USA, my dear friend, Dr. Eyal Simchi. Dr. Simchi has an inspiring career and unique pediatric dental practice. Please let me introduce Dr. Simchi with important remarks in his very successful career. Simply, the motto of Dr. Simchi is maybe that the magic of making children feel special. Dr. Simchi is living proof of someone who lives life by example. His love of children comes from his mother, who is an elementary school teacher who never fails to bring a smile to the faces of her students. Having completed his training, he has worked in several prestigious pediatric dental offices before having the opportunity to open Riverfront Pediatric Dentistry. Dr. Simchi continues advancing his knowledge in pediatric dentistry with continuing education classes incorporating the latest technology and techniques from all over the world. He was recently featured in the New York Times article on his use of silver-diamine fluoride. From a waiting room filled with activities, exciting aquatic decor to his awesome magic tricks, Dr. Simchi has the unique ability to make each child look forward to going to the dentist. He's currently working in New Jersey, and he's the owner of Riverfront Pediatric Dentistry Office. Welcome to CPD Talks, my dear friend. How are you? It's our honor, it's our pleasure to meet such a great clinician, such an inspiring name of pediatric dental community. We are very happy to welcome you. What time is it there?
It is now 2 o'clock, 2:02 p.m.
2 p.m. All right. Here is 9 p.m. in Turkey.
Oh,
we have too many audience from all over the world. So first, I would like to begin with showing some of your magic skills videos, and then we can talk about other things.
Sure.
All right, I'm sharing. I would like to watch again. So I would like to show another video of their magician. So let's begin our questions. We have great questions to this great clinician. So I would like to begin with the first question. It's related to your magic skills.
Sure.
All right. Let's have a check, please. All right. In the world of pediatric dentistry, blending the art of magic with dental expertise is truly innovative. Could you take us back to the beginning and share how the idea of integrating magic into your dental practice came to be? What inspired you to make this unique approach? So, here is the question. How you first came to blend the art of magic with pediatric dentistry?
So it actually happened when I was in dental school. A lot of people assumed that I was always into magic as a kid, but I never really followed magicians, and I was like every other kid. It was interesting to me, but it wasn't like a real passion of mine at all. And it really started when I was in a mall one day, and there was a magician in the mall, and he was doing the trick that a lot of people have seen with the red light trick. And I watched the trick, and it was pretty amazing to see him do it, and I really couldn't figure out what he was doing. And that was almost where it ended. But I was there with my wife, and she mentioned that, you know what, I was considering doing pediatric dentistry at the time when I was in dental school. And she was like, you know what, if you're working with kids, maybe this is a good trick to learn. And, I was smart, and I listened to my wife, and I bought the trick, and I brought it back to school with me, and I tried it on some patients. And it was really eye-opening to see the difference with some of these patients that were so nervous and didn't really want to interact with me at all because they had bad experiences with other dentists or with doctors, and they just associated anything in the medical world with something scary. And when I came out there, and instead of starting sort of within the dental part of the process, I instead was showing them a cool trick that they could look at. Even if they were nervous and hiding behind somebody, they could, peek out and see the light disappear and reappear. It really made a big difference right away. And then over time, as I noticed that, a lot of pediatric dentistry is misdirection. It's framing things in different ways, and it overlaps with magic a lot. So just from that one magic trick, I now know probably 50 to 75 different magic tricks. As they get boring, I learn some more. But that's really where the process started.
Right. Thank you very much. The second question. The mastering art of magic to enhance the dental experience of children is fascinating. Were there any specific course, training programs, or maybe mentors that played a crucial role in developing this unique skill? How did this experience shape your approach? So here is the question. Are there course or special training programs that helped you develop this magic skill?
So what I usually recommend to people who are trying to learn the tricks is YouTube. I didn't really take any courses, but I watched a lot of YouTube videos, and I tried out the tricks on my kids. And if they worked on my kids, then I brought them to the office. So there are plenty of tricks that I tried that just never worked out, and I have a drawer full of props and different parts of tricks. But really, I find that I didn't take any specific course because I didn't really want to make my magic tricks a main focus of the practice, and I didn't want it to be just one type of magic trick. I really wanted to have a lot of different options, which is also how I do my dentistry. I want to have as many options as I can for whatever situation comes up. So I watched a lot on YouTube. A lot of the websites that sell magic tricks will also give you tutorials on how to do the magic tricks. And that's really what I did. I looked at social media and YouTube, and every once in a while I would go into a magic store, and if there's a magic store wherever you are, they're very happy oftentimes to teach you how to do the tricks. And it doesn't take a lot of work. I'm not a very skilled magician at all. I got pretty good at the tricks I know, but I'm not a very talented magician. I hope my dentistry is at a much higher level than my magic tricks are. So really, for people trying to figure it out, I think the best bet is to start with a few simple tricks that you can get online, watch some YouTube videos, and then really just play around with it and make it your own. So, when I learn a trick, I try to see how I can relate that to what I'm doing when I'm doing the trick. And that's what really works for me versus just having, here's some magic tricks and now we're going to do dentistry. I try to incorporate it all together.
As I know that you are part in the book of Dear Kubiaski, am I right? You did it right.
Yes.
We had talked on social media, right?
Yeah.
As I know, the magic as a distraction method is not valid in AIPD guidelines. Am I wrong?
Yeah. So as of now, there are studies on using magic within medicine, but it's not, as far as I know, an official guideline at this point.
You seem to be the first one of using such a skill in pediatric dental practice. Maybe all dental disciplines, within all dental disciplines, and I think it should be within the AIPD's guidelines for the behavior management techniques. The next question is about minimal invasive dentistry. As you said that you rather to be a pediatric dentist who is using minimal invasive dentistry more than being a magician. Your commitment to minimal invasive dentistry for children sets your practice, mostly, as we can see from social media too. Can you delve into the philosophy that underpins this approach? How do you believe it impacts the dental health and overall experience of our young children? So, here is the question. What's your philosophy behind focusing on minimal invasive dentistry for children?
So my main goal in general is to try to make the experience for the patient as ideal as possible. And I know that in the past I've seen things written up in different journals and seen online where people comment that they're not so thrilled about the idea of the minimal invasive dentistry. And I know that even in people higher up in organized dentistry were saying that minimally invasive dentistry techniques like the Hall techniques and stuff like that oftentimes are just a temporary measure and they're not really effective long term. And I do find that the magic without the minimally invasive techniques and the minimally invasive techniques without the behavior management is not the full picture. Because if, for instance, you take the situation where a patient is going to be put to sleep in the operating room, generally there are two components that will determine if the patient is getting put to sleep. It's either because the patient can't tolerate the treatment, even if the treatment is not very invasive and is very simple to do. Or on the other hand, it may be that the patient in theory would be able to tolerate treatment, but that the treatment is so invasive that it's just too much for that specific patient. So I find that if we mix the behavior management together with minimally invasive techniques, we're really addressing the whole patient together. And that's where we find the success in being able to treat these patients without trauma, without sedation, without using a papoose board or any kind of stabilization, because we're really approaching it from both sides. So for me, the more I do less dentistry, the more I realize that minimally invasive dentistry is not just a compromise. It's really how I should be doing this. And even before Dr. Hall came up with the official Hall technique, I was doing similar things with crowns where I would just prep minimally, because I realized that there are studies that show that sealing decay stops the process. And if it stops the process, why are we drilling out all the decay if we're sealing it anyway? So all the studies that are being done now on minimally invasive techniques, almost every single thing kind of proves this, that doing less actually is better for the teeth. And it's definitely better for the patient, especially for a younger kid. If I don't have to do any kind of injection, or if I do a minimal amount of using of a handpiece, or sometimes in many cases no drilling at all, I can get the same result as I used to get when I was taught in dental school and residency, and really in many cases an even better result without doing as much. So it's helping the patient, it's helping the tooth, it's helping the parents because it costs less. So for me, there's really no downside to it. And the only thing that I feel like maybe stops people is just not knowing how to do it and not knowing that it can be done and how well it works.
So how is the general situation in USA, in America? How is the general perception of patients or parents, especially, towards minimal invasive dentistry?
So luckily in our practice, because people know of us already, as a general rule in the US, medicine and dentistry is really reactive. There's a lot of more aggressive work, I feel at least, towards doing more versus trying to address what's causing the problem in the first place. And I feel like being proactive towards your dentistry, for me at least, and I think in general, should really be a better way to look at it versus saying, okay, this is what happened. The patient now has a hole in their tooth. Now we're going to have to fill it or do a root canal or whatever we have to do. If you can be proactive and you can address things and teach the parents beforehand and try to catch things early and use a medical approach towards treating decay versus always a surgical approach, I feel like you have a better outcome. So in dental schools and residency programs in general, they're still more old school. There are a lot of programs that I've spoken to that are really now moving more towards minimally invasive, which I'm thrilled to see. But in terms of the parents, for us, I don't really have to sort of sell the idea to the parents because most of our patients are coming because they heard this is how we do dentistry in the first place. So we're not surprising them by saying, you know, oh, you think you need a root canal, but we're not doing it. They're actually coming to us in the first place because we're not doing it. So I do find that because we're known as the practice that does less invasive dentistry, we don't really have to convince anybody about it. But every once in a while, there are patients that, you know, know more about how dentistry has been done in the past, and it's a little shocking to them that, you know, we're not numbing for many things that we do, we're not drilling for many things we do, and it's a big change from what they're used to. But I haven't really found a lot of pushback. I feel like people are very open to it and very appreciative because it's so helpful for their patients and for their children, and it really, there's only an upside to it, there's no downside to it.
Yeah, great. Another question will be about a very important phenomenon in pediatric dental practice. As you know, there are two parts of dental practice. As one of the world is arguing about minimal invasive dentistry, supports minimal invasive dentistry, and the other parts, full mouth zirconia crowns, as you know. So here is the question. Every child deserves a small VC. Every child should leave dentist without tears. I would like to expand this question. As I know, you have 6 children, am I right?
Yes.
I would like you to answer this question with 2 ways, as a professional pediatric dentist and as a father. Because as you know that the ECC, early childhood caries, are very common in preschool children. So the dentists who are supporting general anesthesia and zirconia crowns, they say that it is very important for preschool children in terms of oral health related quality of life or peer victimization, peer bullying. So we should make very beautiful zirconia crowns. We should give them a very beautiful smile. This is the main argument for many, especially young dentists. And dentists like you who are supporting minimal invasive dentistry, me too. My philosophy is that every child should leave dentist without tears. What do you think about this important phenomenon?
So I'm going to answer first from a dental perspective. I think like with everything we do, there's a spectrum. So, you know, I was speaking to some of the dentists that work with me, and I say, like, we live sort of on a scale. And on the one side of the scale is beautiful restorations and gorgeous looking teeth. And the other side of the scale is the patient's happiness and comfort. And you have to find your balance in that scale to keep your patients healthy, but also keep them happy. And it's a balancing act to do that. So when the argument is made to put a child under general anesthesia because of how they're going to look, I understand that if you don't have any other option. But with minimally invasive techniques, there are a lot of things that we can do, even with early childhood caries, that still look beautiful. So it may not look as nice as zirconia, but I don't need it to look as nice as zirconia because from a normal distance, the patient looks perfectly wonderful and way better than they did before we did the treatment. So that being said, I believe that there is still a place for sedation because there are sometimes no other options, but to just justify putting, let's say, a 2-year-old under general anesthesia because you want to make their front teeth look beautiful, at that age, the patient doesn't really care. They're not at school. And if we could just buy time and stop the cavity process, then we can do a more beautiful restoration when they're able to sit for, you know, at that stage where it really makes a difference. I can't remember the doctor's name right now, but I remember learning from a very smart doctor. He said, if a house is on fire, you call the fire department, you don't call the carpenters. So I feel like it's the same thing with the mouth. If you see a patient who has rampant decay and has early childhood caries, we don't need to start looking at it as like a carpenter. We need everything to look perfect right now because, you know, I was taught in residency, always remember that the teeth are attached to a person. And right now there's a fire going on. There's decay everywhere. We really need to do caries control first. And it's going to be actually a double approach because when you do these less invasive techniques and are using them as carie control and stopping the process, because they're so easy and there's so little invasiveness going on, you're actually training the patient to be able to tolerate dental treatment at the same time. So not only are you stopping the process, and I've found this many times, there are times where I'll do a temporary technique on a patient because the only way I could do something more permanent is either traumatizing the patient or discussing sedation. So we'll do something temporary. And by the time that temporary thing loses its effect, the patient is already a much better patient in the chair. They're used to us. There's already a trust built, and then we can do whatever we need permanently. So I can do zirconia patient crowns on patients in the chair if I need to once we get to that point. And, you know, thankfully it's pretty rare that we need to do that. But I do think that just thinking that it has to look beautiful and that's the most important thing it forgets the patient that's attached to it. And sedation has risks. General anesthesia has risks. There are studies being done now on the effect on the developing brain, and we know it has an effect. So to justify putting a kid under general anesthesia for cosmetic purposes, especially when the alternative is not so much worse, I don't think is a great approach. And from a parent's perspective, the same thing. I don't like doing more medical interventions than absolutely necessary. When patients ask me in terms of looks, I always tell them that if it was up to me, I would do it a certain way if my wife gave me permission to do it that way. But again, like the minimally invasive techniques do not have to look ugly. We do use silver fluoride very often, but we use it in areas where it's not noticeable, and we have different things that can block the color. There's now, I don't know if you guys have this available in Turkey, but there's a material out of Switzerland called Curodont, which is another medical treatment of decay that does not change colors to the tooth. So we have a lot of options to keep our patients' smiles beautiful without putting them through sedation or general anesthesia.
Curodont is not available in Turkey, but I gave a lecture in Romania in an international congress, and they did promotion. As I know, Janet McLean is the main person who is showing Curodont. I'm using silver diamond fluoride in my routine practice, and I'm very happy with its activity, antimicrobial activity, and arrest activity. What do you think about the oral health related quality of life and peer victimization in preschool children? Is it common or not?
I think it depends on the area you're in. Like in the US, there are so many different areas and so many different sort of demographics of people. So in some areas, they keep it much more on the top of the list of importance than others. I was doing a school presentation, and one patient didn't want to smile. And when she finally smiled, somebody had done stainless steel crowns on all of her front teeth. So that is something that I would probably never do because I have other options. So I definitely think that it is something that's important to take into consideration. But most of what I do is case by case and kid by kid. And I will discuss that with parents, that if it seems like it's being noticed, or if it bothers the patient how it looks, or classmates are mentioning, then we'll discuss another option if we have to. So we try to have as many options as possible, and I wouldn't disregard that as one of the things on the list of decision-making criteria. It's not on the top of the list, and I don't think for most patients it's at the top of the list.
Sure.
But for instance, with silver fluoride, generally I offer it as an option for anterior teeth to parents, but I told them that it's not my recommendation. Meaning, if they want the least invasive thing that will help stop the process, silver fluoride will do that. But I'd rather do a glass ionomer strip crown, which looks beautiful and can also, it's a little step above in terms of invasiveness, but it's not difficult and it's not painful, and will have a nicer looking outcome. So it is something that I put into my list of things to consider, but it's not super high on the list because we have so many options that keep it looking beautiful anyway.
Sure. I know that you like, as me, glass ionomer cements. I think it is the most important material of pediatric dentistry, and it has a great development process within the years. So I think each pediatric dentist, I'm calling to young colleagues who are watching from all over the world, they should use as the base material in their dental practice. They should be used to using it. As you have described, navigating the best approach for pediatric dental care may be sometimes very challenging, especially when considering options like general anesthesia versus multiple appointments. Based on your extensive experience, which option do you find more manageable for children and why? How do you make these decisions in the best of your patients? So here is the question. Which is more manageable for a child, undergoing general anesthesia or attending multiple appointments?
So I would much rather lean towards multiple appointments. And there's multiple reasons, but one of the reasons is that general anesthesia, in the studies in the US at least, kids going under general anesthesia, it's not a guarantee that they're not getting any more cavities. And I think studies show up to 50% of patients that are put under general anesthesia end up being put under general anesthesia for dentistry again, which means that it's not helping as much as we think it's helping anyway. And besides for that, it's also not teaching the patient how to be able to tolerate treatment. We want our patients to grow as dental patients because they're going to be needing to go to the dentist their entire life. And patients that are sedated or put under general anesthesia, very often after all that work is done, when they go back to the dentist, they're not as, they're not any more happy than they were in the first place because they were never acclimated to the dentistry. They were never shown that it can be done without any fear. So they're not really learning how to be good dental patients. So it is a difficult thing sometimes for parents because in the parent's mind, if you just put the patient to sleep, you're done, you did it once and you're finished. But for me, I reserve that to when there's no other option because for me, the risk of general anesthesia is super small, but it's not a risk of a headache. It's a risk of a patient not waking up. And if I don't need that 100% with certainty, I'd rather avoid it. So I tell parents that we spend a lot of time with the first few appointments. And oftentimes when I speak to other dentists, they ask me, how do you have time to spend that much time on an appointment? But all the time that I spend up front, I save at the end because once I build trust with that patient, I don't have to worry about having a patient fighting me at every step, every single appointment. In almost all cases, as we work with them over time, they get more and more comfortable at the dentist and those appointments become less and less difficult and less frequent because once we can stabilize everything and get them back onto a regular recall schedule, obviously the time involved initially with 3 or 4 or sometimes even 5 appointments is more time. From a financial perspective in the dental office, I'm obviously making less money doing that, but my goal is not how much money is in my bank account. My goal is how much I can help my patients, and really we're focusing on changing this generation of patients, of people who are terrified of going to the dentist, into patients who are actually excited about going to the dentist. And we have patients every day where the parents tell us that the kid threw a fit and was crying because they didn't get to go to the dentist. So if we can change that for as many patients as we can, that happens with seeing your patients and interacting with your patients, not just putting them to sleep, doing whatever treatment you have to do, and then you're back to starting the same thing the next time.
I think that dental trust is one of the most important components of behavior management. I agree with you.
Absolutely.
So within my experience, I see that getting the trust of children is more easier than getting the trust of parents. In my routine practice, I give very much attention on parents' expectations. So if I am thinking about a minimal invasive treatment option, I always check the oral health behaviors of parents, not on the child, but the parents. So what do you do if the parents do not want to come on multiple appointments? Do you insist on calling them or other things, or you say bye-bye? Which one?
So we try to have the parents understand the importance of it. And thankfully in our practice, we've gotten to a point where the parents, a lot of them are traveling very, very far to see us. There are patients that drive 10 hours each way just to come to our practice. So because we have already set up the practice the way it is and patients know that we have their child's best interest in mind, I find it that we don't have to really sell that idea of the importance of it because they're coming because they know the importance. That being said, there are definitely parents that make it more difficult because they don't find it as important and they don't want to come back. But we do have a system within the office that we have the staff calling and saying, there's treatment that needs to be done and you haven't returned. So we do try to follow up, without it getting annoying and pushy. But we don't just dismiss them from the practice because they're not following our guidelines. We try to, I feel like even if I can make a small difference in their life, for me, it's worth it. So if I can get a little change in their diet or a little change in their brushing habits, and we actually see a turnaround sometimes even with the nervous parents. There are parents that tell us that after seeing how well their child has been able to do dentistry, they finally went back to the dentist after many years. Because a lot of the, sorry about that, a lot of the sort of pushback from the parents of taking their kids to the dentist is because of their own fears that they had. And if we can kind of gain the trust of their parents and realize that it can be non-invasive, it can actually not only be not scary, it could be fun for the patients, it changes the parents' perspective on it as well.
Thank you very much. A related question, a class question to the previous one. Engaging parents in the dental care process is crucial for a child's dental health journey, of course. Can you share your strategies or methods for involving and managing parents within your practice? I'm talking about the operation room, especially. How do you address their concerns, manage expectations, and foster a cooperative relationship? Any tips or tricks? So here is the question. How do you involve and manage parents in the dental care process?
So the number one thing I find is education. So having the parents understand how we run the practice is number one. In terms of involvement during the treatment, we actually try as much as possible. We want the parents to know what's going on, and we want them to be doing their part at home. But during treatment, in most cases, we try to keep all the behavior management to us. And one of the things that I tell parents is that oftentimes parents really want to make things easier. But they don't always realize how it comes across. So for instance, if a parent tells their child, don't worry, it's not going to hurt, the child hears the word hurt even without the it's not. Like they heard that word hurt in the sentence and their brain is already going to, wonder why would we even consider it's going to hurt? Because if, for instance, the mother takes the child to go buy new shoes, they don't say, oh, we're getting new shoes, don't worry, it won't hurt. So even if their intention is all positive, just the way it comes out without them even noticing can be negative. So that's why I typically will tell parents, if, for instance, let's say a patient needs to come back in a week for an extraction and the parents ask me, what should I tell them? I just tell the parents, tell them that we're going to come back and the doctor's going to tell you everything he's going to do just like he did at the last visit. And then I'll address all the concerns. So that way we can tell the patients in a way that they can understand it and reframe it and make the entire process a lot more comfortable because we don't have the patient thinking about it the entire time. Meaning if a mother spends or a father spends the entire week during that appointment saying, don't worry, we're going to the dentist, he's just going to take out your tooth, but it won't hurt and he'll be gentle and don't worry, it's only a small shot. That patient is only going to hear pulling teeth, shot and hurt, and they don't care that it's not. They just, when I was in residency, we had a patient come into the chair and the mom sat in the corner and she was praying. And I remember my director went to the mom and said, definitely if you want to pray, pray. But if you're praying in front of your child just now and you're not doing that all the time, your child is probably terrified, wondering what's going to happen to them because mom has to pray for them now. So, praying is important, but you have to see how it comes across to the mom, to the patient. So from a parent's perspective, we try to get them involved with sort of the oral hygiene and home care and all that. But when it comes to the behavior management, we actually try to separate them from that part because it makes it a lot easier for the patient to focus on us. And we're the ones who have done this long enough that we know in most cases that will keep it as easy as possible for their child.
Yes, the parents should see that the control of the operation room is for the dentist. The integration of technology and innovative methods in dental practice can significantly enhance patient care, we know. How do you incorporate these advancements in your daily practice, especially in the realm of dentistry? Are there specific technologies or approaches that you have found particularly beneficial? So here is the question. Do you also use any additional technological or methodological innovations in your daily practice?
So I try to keep on top of anything that's coming out that can make my patient's life easier. So we do incorporate things, but really up to a point. When I first opened my practice, there was a company that reached out that had a robot that would interact with the patient sort of at their level. And it was a very cute idea and a very nice idea, but I did find that after looking into it long enough, I was doing everything that the robot could do, and I was doing it the way I wanted, which was even better. So I feel like each practitioner has to decide like what specific things that they need. We use intraoral cameras all the time for patient education, for the child and for the parent, because oftentimes if the patient can see themselves what's going on, it makes it less frightening. When something's going on in your mouth and you don't know what's happening, there's noises and taste and smells. It's a little scary, and especially children with great imaginations imagine the worst. But if they can actually see what you're doing, which is, a more enhanced tell, show, do, it's definitely very helpful. For diagnosis, we're now looking into, there's now AI related programs that can look at x-rays. And I find like for minimally invasive dentistry, I haven't started using it yet, but it's a good idea to be able to track the progression or not progression of decay to help make a decision. Okay, wait, this hasn't progressed in a year. We're just not going to do anything about it other than maybe silver fluoride, versus if we see something that is progressing, we can discuss other options. I know there's a new thing out now in the US. I don't know if it's available in other countries. It's called the Soin. I think it's out of France initially, which is it's similar to the wand injection system, but it's a more advanced version of it where it's like an electronic injection system. I've tried those in the past and I didn't love them very much. And thankfully, I've gotten pretty good at injecting, so I don't have that in the practice. But that is something that a lot of people like. So I really feel like it's practitioner by practitioner. You really have to find the technologies that fit within your practice and what you're looking for and the things that can kind of like up the either success or the ease of what you're doing.
Thank you very much. Adopting a unique and very innovative approach in pediatric dentistry comes with its own set of challenges and rewards. Can you share some of those obstacles you have encountered in implementing your approach? And on the flip side, what have been some of the most rewarding moments or outcomes you have experienced? So here is the question. What challenges and rewards come with your unique dental approach?
So that is a wonderful question. It's a very good question, because it comes with both and a lot of both. So the challenges are the same challenges of anybody trying to do something different. So, I was taught a certain way in dental school. Lucky for me, I am sort of the personality that I don't love following rules just because they're a rule. And I'm a very curious person. I like thinking outside the box. And I was very, very lucky to go to a residency program where my director was open to allowing me to sort of try things versus just sort of making the rules for me. So that really gave me the opportunity. But there are challenges because if you look at something and it says it in the book and you do it, then you're doing what the book says and you're kind of covered by that. When you're kind of pushing the limits, there's challenges with, within questioning yourself. At the beginning when I started doing things like this, I was like, maybe it's just my ego and I think it's working better than anybody else, but maybe I'm just full of myself. So I actually started asking hygienists that work with me that also worked in other practices if they were seeing more failures in my practice versus in other practices. And across the board, the answer always was that they were seeing less failures in our practice. So I was like, okay, that's good to know. It's not just in my mind, it's actually working well. But it's also just within organized dentistry, it's hard to go against what people have said forever. I know when I was in dental school, they said, for instance, with orthodontics, if you wanted to do an expansion on the palate, you can only do it until the suture of the palate is fused. Once it's fused, you can't expand anymore. And there are orthodontists near me that are expanding adults' palates. So just because it says it in the book doesn't mean that it's written in stone, and things change within medicine all the time. But it's very hard to be that person who's sort of making that change because there's a lot of pushback. So I'm a big dental nerd, so I'm part of a lot of different Facebook groups and different websites. And I've had many people question what I do. And, I understand their perspective because it's hard to change. But those challenges for me only make a difference if it's my own ego. So if I put my ego aside and I don't mind getting attacked for it, and I know I'm doing the best thing for my patients, it really makes that not much of a challenge, and I'm seeing the results. So for me, the advantages way outweigh the disadvantages. So again, like there's the challenges of anything that's not by the book because you have a risk of it not working, but I try to do everything with a science-based approach, and I try not to push the boundaries too much. I do like step by step and little by little. And, I've been doing this for enough years that it seems to be working. And on the other side, the sort of the successes, it's just really amazing to see patients that were coming into your office after having a bad experience and they're shaking and crying. And, less than a month later, you can't even tell it's the same kid because they're so excited to come to your office that they ask their mom every day, when I'm going back to the dentist. We have parents that after their appointments, the mom is crying because they never expected that their child would be able to have treatment done and do it happily. So for me, just seeing those successes, and we really see it every day because in our area, it's very common to refer for sedation and general anesthesia, and a lot of the parents are nervous about it. So pretty much every day we have patients coming for a second or third or fourth opinion, and in almost every single case we're able to successfully complete all their treatment without sedation. So it really is a rewarding thing to do.
What was the most challenging patient you remember? Did you ever lose control during dental treatment? Do you remember in a moment?
So the challenging patients for me are the ones that I'm able to maybe start the process, like get the patient numb, and then not able to complete the process. So there are times where we'll be able to get a patient calm enough to get numb, but for certain patients and certain children, that numb feeling is enough to push them over the edge. And it's not like something that's a little uncomfortable for a minute. It lasts for a long time. So some of those patients just aren't able to tolerate it. And in cases like that, sometimes we have to send them home without actually doing any treatment. Most of the dental offices around here have 1 day a month, sometimes 2 days a month, where they do sedation or general anesthesia. And we have 2 full-time and 2 part-time dentists in the office, and we refer maybe tops 3 patients for anesthesia to another practice per year. So we really try to work as hard as we can. And I feel like if I have a patient that does not have any pulp involved teeth, so I don't have to worry about extractions or pulpotomies, I think with like 99% certainty, we can stabilize that dentition until the patient is old enough to get more work done if they need it. And in most cases, we're able to stabilize the dentition. They don't even need any more work. The challenges are once there's pulp treatment needed, and those patients sometimes are tough with being numb or just a longer appointment. Those can get challenging, but because of the minimally invasive techniques that we do, we really avoid it. We don't do a lot of pulpotomies. I don't remember the last time I did a pulpotomy on purpose. Right now we do LSTR if the tooth is abscessed, but if the tooth does not show any signs of pulpitis, we just do indirect pulp treatment, and the success is amazing. So the way to avoid those failure type of cases is to try to be prepared for them beforehand.
You said that LSTR is very common in your dental practice, right?
Yes.
How is the outcome?
So far, I think we've probably done thousands of them, and at most we've extracted, I think, 1. Every once in a while, when we find that the bone is not filling in like we wanted to, or we see that there's an abscess that comes back, we'll reopen the tooth and pack in more LSTR. But we've been doing it pretty much since it's been available as a modality in the US, and we've had great success with it.
Was there any Turner hypermineralization or similar hypermineralization in tooth?
No, I actually have only 2 patients in my practice that I've seen Turners. One of them was a patient that the only thing we ended up doing was extracting a tooth that somebody else had done a filling in, and I still don't know why it's a Turner tooth because I didn't see any abscess. It was just ongoing pain for that patient until I extracted the tooth. There was nothing that we could do, and I still don't understand that situation. And then the other Turner's tooth I saw was a long time ago with a long-standing abscess, but we haven't seen any post-LSTR.
Yes, yeah, right. Is there any clear indication, or how is your decision process for putting a child on a general anesthesia after 2, 3rd, 4th appointments failure or anything else? Do you have any clear indication, or what's your decision process for general anesthesia?
I always approach the first appointment with the last appointment in mind, and I always tell the parents, if the first appointment is not happening, then it's very unlikely you're going to get to the end. But what I do find in most cases is that if we can get the first and second appointment done with the patient comfortable and happy, in many and most cases, as we progress, it depends really on the patient's personality and their age. But if we can build that trust, even if the patient is not always super thrilled with it, if they trust us enough, we can almost always get the work done. It's pretty rare for us to start treatment and then send the patient for sedation. Generally, if I don't feel like there's any chance that the last appointment is going to go well, then we'll send them from the beginning so that we're not pushing. And again, it only happens generally at most. I think our biggest year was 3 to 4 patients that we do that for.
You use sedation in your routine dental practice, am I right?
No. We use laughing gas only, nitrous oxide.
Nitrous oxide.
We don't use any oral sedation or IV sedation.
You use what about nitrous oxide sedation? Do you need any? What is the legal procedure for using NO in dental practice in the United States? Do you need any course or certificate or other things?
So in the
anyone can use in routine dental practice, whoever wants.
So it depends on, I think, the state that you're in. Different states have different guidelines. pediatric dentists in the US, when we get our pediatric dental certification, we're trained in nitrous oxide sedation, but also oral sedation, and in some programs, even IV sedation. So when I finished my residency program, I was also allowed legally to do oral sedation, but I've never done it since I graduated. So it depends on your state board what the decisions are. But for nitrous oxide, it's not as strict as most other. When it's nitrous oxide together with other medications, or if you're going to moderate sedation, then there's a lot more guidelines.
Why don't you prefer oral sedation? Because I have traveled in many countries and visited very popular and eminent clinicians from all over the world, and most of them prefer to use oral sedation. What is your concern about using oral sedation in practice?
So with me, the concern that I have is that in the U.S., every bunch of months who had sedation and doesn't wake up. So, and not only that, but when I was the main reason that I sort of stayed away from it is that I felt like in residency, when we were doing sedations, the sedations that were successful and the patient was calm and comfortable, I felt like I probably could have done the same thing without the sedation. And the patients that were that much more difficult, the sedation didn't seem to do as much as we wanted it to. So it may also depend on the medications that are being used. Some people use 2 medications, some use a triple cocktail. So it depends possibly on the training. I felt like in my residency program, the cocktail that we used wasn't super great at sedating the patient. So if a patient was not happy and not calm, it didn't really calm them down very well. And if it did work, most of the time, those are patients that probably could have done it without the sedation. So for me, I didn't feel when I finished residency that I was trained in sedation to get them sedated enough that I'd be comfortable doing that to my own kid. And if that was the case, I definitely wasn't going to do it to somebody else. So that's sort of what guided me away from sedation.
Thank you very much. You are very popular in social media in all over the world. For fellow dentists who are inspired by your innovative approach and maybe eager to adopt some similar practices, what advice would you give? Are there particular steps, considerations, or pieces of wisdom you would share to guide them in integrating this unique approach into their pediatric dental practice? So here is the question: what advice do you have for dentists eager to adopt a similar innovative approach in pediatric dentistry?
So I think it's the most important thing is really 2 specific parts, to me at least. Part number 1 is being open-minded. If you don't know that something is even possible, then you can't even imagine doing it. So for example, when I was in dental school and residency, if a patient came in and needed 6 crowns, it wasn't even a question that they were going to be put under general anesthesia, because nobody even considered that a 2-year-old could get 6 crowns done without general anesthesia. But if you know that it's possible, then you know that you can try things. So I think the number 1 thing is being open-minded and questioning what you learn to make sure it makes sense and seeing if there's other options available. So you have to really be open-minded to even consider that. And then once you're able to consider that, just learn as much as you can from as many people as you can and as many techniques as you can. Because even within like the minimally invasive dentistry, I still don't think that schools should stop teaching conventional dentistry, because to be able to do good minimally invasive dentistry, you need to know the sort of the basics and the building blocks of dentistry.
Sure.
So, if you can't do a good prepared stainless steel crown, it's going to be harder to troubleshoot if you have trouble with a whole crown. So I really feel like the second part, besides for being open-minded, is just try to learn as much as you can. I try to read whatever I can. I read from dentists all over the world, because there are certain things that are available and done in other countries. Glass ionomer is barely discussed in dental school in the US. At least when I was in school, glass ionomer was almost not discussed at all. And these days, it's what I use more than anything else. So it's really important to try to learn from as many people and as many techniques as you can. And that gives you the options to see, okay, this works for me, this doesn't work for me. Because, I don't think that everybody has to do dentistry the way I do it. I try to teach people so that if they want to do it, they can. But everybody has to find sort of their perspective and their way of doing things. And for me, this works best for my patients, and thank God we have an amazing outcome from it. But it's really a mix of being open-minded and learning as much as you can.
Can you have any tips or tricks for behavior management in children under age 4, especially?
So the number one thing I find helps me is disconnecting yourself as a person versus as a medical person. Because most of the time, patients have seen pediatricians before they saw their dentist, and most of those pediatricians have given kids shots at that point already. So they already know in many cases that they don't like medical people. So my first goal when I see a patient that's under 4 years old is to have them see me as a person, not as a medical person. So magic tricks, balloon animals, prizes, dumb jokes, whatever you can do to kind of get them to interact with you, not in a dental way, is the goal for me. When we have patients that are very scared to go to the dentist, sometimes we'll just have them come to the office just to meet us, get a prize, and go home, so that they realize that, you know, just because they're coming here doesn't mean something's happening that they don't want. And what I do find was very helpful in our practice is for a first patient visit when they're young, we don't push anything. So if the patient is able to tolerate a cleaning and needs a cleaning, we'll do a cleaning. But if they're not happy, we'll just get our exam done as quick as possible, try to distract them with whatever we can to distract them, you know, do a fluoride treatment if we can get away with it, and send them home. Because I'd rather them just remember the good parts of the first few visits, because that will save all the time for the next visits. Once you get that trust, everything else becomes easier. But if you start your first appointment with a 2 or 3 year old and you're already having the parents hold them down lap to lap and you're brushing their teeth while they're screaming, when they come the next time, they're not going to forget that, and they're going to assume the same thing's happening. So I'd much rather spend the time and just gain their trust and make a relationship with, so that they realize that you're a person that's nice and caring and helpful. And then when you get to things that may be a little more uncomfortable, they already know you, so you're not jumping into it right away.
Do you meet the child? Do you meet the patients in waiting room generally, or always?
Yeah, almost. I mean, I try to make it happen always. It doesn't always work out scheduling wise, but I try my hardest to meet them in the waiting room before we ever go into the back.
I think dental staff is very important for child-friendly dentistry. Do you give any additional education to your dental staff?
So we don't do a specific like formal education for them, but we try to hire people that are very good with kids, and they sort of learn over time just from the techniques that kind of rub off. There are some of our staff that knows how to make balloon animals, some will do magic tricks. They kind of know how we work. So we don't formally train them, but they realize how our practice is run different than other places. And, you know, over time that works together with us.
A small question. Which one is better for preschool children in the labs of his mother or father, or knee-to-knee method? Which one do you prefer mostly?
I'd much rather on the parent's lap. I feel like knee-to-knee may be a little easier for me as a dentist, but I don't do knee-to-knee very often at all. I usually keep them with the parents on their lap.
All right. The next question. The future of pediatric dentistry holds endless possibilities for innovation and development, as you know. As looking forward, what specific innovations or in this field are you most excited about or hopeful? How do you see these developments transforming pediatric dental care in the years to come? How do you see the future of pediatric dentistry in the future?
I really want to see it push towards preventive versus restorative. So as much as possible to try to prevent cavities with education, with using medical approach towards caries. You know, they're doing different studies on hydroxyapatite and probiotics, and, you know, instead of looking at it as a surgical specialty, seeing it more as a medical specialty and seeing if we could avoid dentistry in the first place, I feel like is really my goal.
Sure. Thank you very much. When I talked to my colleagues, when I shared our banners on social media or other things, especially my young students, junior students, did ask me to ask some questions to you. They are very simple for you, but they are very important for them. All right?
Absolutely.
They would like to learn about local anesthesia. Let's talk about tips and tricks. All right? Very easy question. Topical anesthesia. What do you prefer?
So I get mine.
Benzocaine, which one? And any tips, tricks?
So I actually use a combination of lidocaine and prilocaine. I have it compounded by a pharmacy, but the trick for topical anesthetic to make it work is making sure that the tissue is dry. And another important trick that's not really related to the anesthesia part of it, but is related to really everything we do in dentistry, but also especially anesthesia, is preparation of the patient beforehand. Because discomfort in dentistry is not just pain. For a lot of patients, it's anything they don't like. So sometimes it's just the flavor of the materials. So if we do it and then the patient tastes it and gets upset, it's very hard to bring them back. But if we prepare them beforehand, then it's a much easier thing to deal with. So if you're going to use topical anesthetic, it's very important that if it doesn't taste that great, first of all, I taste everything that we get, so that way I know if it tastes great. But it's telling the patient beforehand that we're going to do, when I tell them I'm going to put something that's a little bubblegum jelly on their tooth. Some people think it tastes good. Some people don't like if it tastes good, how it tastes. So if you don't like how it tastes, just let me know and we'll, wipe it away as fast as possible. So preparing the patient before every step is super, super important. But for the topical to work, you really want the tissue to be dry and left on for a minute and a half so that it works well.
Sorry, I missed the combination of lidocaine and other.
It's lidocaine, prilocaine,
the
and hang on one second. Let me just get it because there's three things. It's prilocaine, lidocaine, and tetracaine.
Who makes it?
I actually get it made by my pharmacy. One of my patients' moms is a pharmacist, so she makes it for me.
It's very interesting. This is the first time I heard about it. Is it very effective?
Yes.
Yeah. This is a good tip and trick. Do you know the rule of 10? Is it common in
rule of 10 with weight?
No.
For anesthetic?
Age and tooth number. If it is more than 10, inferior alveolar blockage, or if it is lower than 10, infiltrative anesthesia. Locally.
Oh, I like that a lot. The reason we don't know it is because we have a different numbering system for teeth. Our teeth go 1 through 32 and the primary, but right. I actually do that in my brain, not really by doing the math, but I do change what I'm doing based on how far back in the mouth and how old the patient is. But that's a very nice thing. I'm going to look up the rule of 10 for that. That's smart.
So when to use infiltrative anesthesia or inferior alveolar anesthesia, mandibular anesthesia? How do you decide?
So I decide typically based on age. So if they're usually I do it closer to like 8 years old and up, but not for anything. Typically, if it's in front of the primary second molar, I just infiltrate everywhere. If it's the second molar or behind, if it's for a restoration, then generally I'll infiltrate. But if it's for something more pulp treatment or extraction, then I'll usually block. But a lot of it depends also if the patient has an infection. It depends if the patient's super sensitive. There is a nice technique that can work also that has similar success to a block. It's not as great as a block, but it's better infiltration if you do sort of a lingual infiltration on lower molars with articaine. It can work very well because the bone there is a little thinner, so it can get to the roots a little better.
Do you make intraosseous anesthesia?
Rarely. I've tried a few systems that I really didn't like, so I almost never.
Almost never. All right. Please let me check if there are any other questions. It was a very nice talk with you, dear Eyal Simchi. You are a great clinician. In my introduction, I talked about your being a leader, being a clinician, your innovations, because we know that embracing the challenge of pediatric dentistry requires not just skill and knowledge, but a deep compassion for our children, patients. Success in this field is measured not just by the health of teeth or oral health issues, but by the smiles we nurture and trust we build with the child. Are the common reasons why you are here, why we wanted to invite you, and thankfully you agreed to be with us. Thank you very much.
Thank you.
And we should know that innovation in pediatric dentistry is not just about the latest technology, techniques. It is about finding new ways to communicate and connect with children, to make a good bonding, and to turn their fear into fascination and to inspire a lifetime of dental health. You make all of these amazingly. Another one, you are a leader, clinician in the world for me, because leadership in pediatric dentistry means setting a standard of care that respects the unique needs of each child, advocating for their oral health at every level, and sharing our knowledge and experience to elevate the practice in all over the world.
Thank you.
So I'm very happy to make these CPD talks with you. Many thanks for not only being a super clinician, but also being a mentor, being an inspiring figure for young dentists, for all pediatric dentists in the world. Thank you very much. We are very lucky to have such a great name as the pediatric dental community. Thank you very much for being here.
I really appreciate it. I'm really honored that you asked. I'm really happy to have been able to share. Thank you.
Inspiring. Being a mentor is very important. And luckily, you are using social media very actively. So we can see your great videos. You are very active in Instagram, right? Yes. I'm going to share within the next minutes on my social media and on the social media of CPT. And I'm sure that colleagues who are watching this CPT talks from all over the world would like to see you in the next episodes too. We would like to welcome you. Thank you very much for sharing your very valuable time. Over 1,000 audience is watching from all over the world. And this will be recorded, and other colleagues will have chance to watch after the talks. Thank you very much. You can say your last words.
Sure. Thank you, everybody, for listening to what I have to say. I'm really honored to have been asked in the first place, and I just hope that I gave you some information that you can take into your practice and help your patients. And when you help your patients, you help yourself as well. And really, thank you, Dr. Buldur, for everything that you do for the pediatric dental community. It's amazing to see how much you've done in such a little time, and really made it an amazing forum for other people to be able to see sort of not just one area's thing, but things from all over the world. So it's really amazing, and I really appreciate you.
I'm very honored and a pleasure to hear these words from you. As you know, CPD is a platform for sharing open access knowledge for everyone who have sincere passion for taking care of our young, lovely children. So Contemporary Dentistry Journal is free, CPD Talks is free. They have chance to watch such great names from all over the world. Thank you very much. Hope to meet you maybe in a face-to-face congress or other events. It's my pleasure. Bye-bye.
All right. Have a great day. Thank you.
Thank you very much. We are at the end of the second episode of CPT Talks. Next week, on the same day, at the same time, we will host Dr. Professor Patricia Valerio from Brazil. We will talk about a very important clinical phenomenon. We would like to see you next week too. Thank you very much. Hope to meet you next week. Bye-bye.